Hello, everyone. Thank you so much for joining us today. Have a few announcements as we wait for everyone to get logged in. First, just want to let everyone know that we are recording this session and it will be available here in Accelerants and for the next 30 days. It'll be available for the next 30 days here and on the Alliance's YouTube channel after that. Secondly, if you'd like to ask a question during the session, please make sure to use the chat or the Q&A area to the right of the viewing window. If you'd like to access English or Spanish captions or Spanish audio translation, please use the widget below this viewing screen, or we dropped a link into the chat to access them from a separate browser window. Finally, this is a webinar type of breakout session. The speaker will not be able to see you, but they will be able to see your chat and your Q&A comments to the right of the panel. So please feel free to use those throughout the session. And it looks like we are ready to get started. So I'm going to hand it over to you, Elena.
Thank you, Matthew. Just going to share my screen. Welcome, everyone. Thanks for attending our session. All right, let's go ahead and get started. So today we're going to be talking about innovative state-based approaches to food is medicine. I will be one of your speakers today. Again, my name is Elena Reese. I'm a manager of benefits integration and health at Share of Strength. And at Share of Strength, we are ending hunger and poverty in the United States and abroad. We do this through effective campaigns and programs like our No Kid Hungry campaign. And I will pass it to Dawn to introduce herself.
Thanks, Elena. My name is Dawn Opal, and I serve as Chief Innovation Officer and General Counsel at the Food Bank Council of Michigan. The Food Bank Council of Michigan is the partner state association that represents the 7 regional food banks that are affiliated with Feeding America and our distribution network of over 3,000 partner agencies.
Awesome. So a quick overview of our session objectives for today. We have 3 main ones. We're going to explore how different Medicaid levers like in lieu of service, Medicaid contract procurement, and value-added services are creating new opportunities to address food security. We'll look at how these tools can help organizations bring food security screening into care workflows and strengthen care coordination. We'll also learn from Dawn and her experience in Michigan. Michigan is one of the earliest states to implement robust nutrition supports through ILOS framework. So we'll hear from her around building relationships within the Medicaid state agency and with managed care organizations. And we'll also talk about the Medicaid Food Security Network. This is a network that's a part of Share of Strength. We provide infrastructure for ongoing collaboration and peer learning across Medicaid stakeholders and food security advocates. And so we'll walk through some resources that we have available, like our policy dashboard, our state supports, and by the end of this session, you'll kind of know what tools that you can use in your community and how you can really start embedding this work. So with that in mind, let's go ahead to the next slide. First, I just want to take some time to ground ourselves in why Medicaid. Medicaid is one of the most strategic places to address food insecurity because of the sheer scale of the population it covers. More than 70 million people rely on Medicaid, and almost half of them are children. Within that group, about 14 million are food insecure, so already connected to one of the largest at-risk populations in the country. Medicaid enrollees are also much more likely to struggle with basic needs. Food insecurity consistently ranks among the top 5 social needs that affect health, and roughly 20% of Medicaid beneficiaries face it on a regular basis. There's also a strong equity dimension of this. About 60% of Medicaid beneficiaries are people of color, communities that are disproportionately left out of SNAP and WIC. And so by engaging Medicaid, we can close those gaps, we can increase participation in nutrition programs and really drive meaningful improvements in health equity. And finally, Medicaid gives us a built-in infrastructure. Health plans and clinical providers have been trusted sources. Ongoing communications with these members are occurring daily. And that means we can integrate screening, referrals, and enrollment supports to existing touch points. So when we think about strategic audience capture, Medicaid is one of the most powerful platforms we have for reaching people who need nutrition supports the most. So transitioning and talking to the Medicaid Food Security Network, this launched in 2024. It's a collaboration between Share Our Strength and Health Begins, and we aim to mobilize the national network of food security champions committed to building the resolve of Medicaid agencies in their leadership and valuing, investing in, and partnering with efforts to reduce disparities in food and nutrition insecurity. At the Medicaid Food Security Network, we offer anti-hunger advocates and representatives from diverse sectors of the healthcare industry opportunities to identify and implement strategies through the Medicaid system that have the potential to address the full spectrum of food and nutrition needs of children and families. We do this through fostering collaboration with peers nationwide, providing access to resources and information on Medicaid programs and policies. And our goal is by 2030 to increase the number of Medicaid enrolled children and families who are connected to federal nutrition programs like SNAP and WIC and complementary FIM programs such as produce prescription, medically tailored groceries, and medically tailored meals, which may also include SNAP and WIC navigation assistance. A little bit more about what we actually do, our core activities that support states and advocates and healthcare partners. First, we really convene and collaborate. A major part of our work is to bring people together. We host quarterly network meetings that include a wide range of food security and healthcare stakeholders. Our next quarterly meeting is actually next Thursday. We're going to share a little bit more about our Food as Medicine cost analysis resource that's in development, along with insights and programmatic experience on integrative approaches to food as medicine and incorporating that with SNAP and WIC. So if you scan the QR code on the right, that will actually drive you to our registration link if you're interested in attending. And we also provide a national forum where partners can connect, compare approaches, and learn from one another about Medicaid's role in addressing food insecurity. Looking ahead a little bit more towards the end of next calendar year, we'll host our second annual National Summit in the fall of 2026. So our first one was held this past May, and it really brought a lot of Medicaid-minded folks together. The next thing we do is inform and influence. We use our insights from our network to really help shape both state and federal policy conversations. We share what's working, what gaps still exist, and really aim to strengthen Medicaid policies that can meaningfully reduce food insecurity and improve health outcomes. We also provide a plethora of resources. We develop tools that states, plans, and advocates can use to support policy change and implementation. Some examples of this include our Medicaid Food Security Network Policy Dashboard. We'll talk about that towards the end of the presentation. We also have a Medicaid and Food Security 101 video series, just introducing folks to Medicaid, and our Promising Strategies document that guides states through effective approaches to policy change. We also publish a bi-monthly news digest and briefs as well, our newest one being on how food as medicine strategies complement SNAP and WIC. And finally, our technical assistance. So through our Medicaid Food Security Partners Program, we provide both funding and hands-on technical assistance to state-level organizations working on Medicaid policy change or implementation with efforts tied to SNAP and WIC. In addition to the funded program, we also provide non-funded technical assistance to states and partners that need guidance as they explore or advance Medicaid food security initiatives. So Dawn was one of our grant-funded partners this past year, with our grant just wrapping up in August. So really just in general, Medicaid Food Security Network, we're collaborators, we're a knowledge hub, and we're hands-on partners supporting the field through collaboration, policy insight, resource development, and technical assistance. Off to you, Dawn.
Great, thanks, Elena. So like was just mentioned, my organization, the Food Bank Council of Michigan, was one of the first in the first cohort of the Medicaid Food Security Partners Program. And that was very serendipitous because it aligned with very closely the development and implementation of Michigan's in lieu of service provision for the offering of food and nutrition services inside of managed care, Medicaid managed care. I'm going to talk a little bit about that and what that means. And if you go to the next slide, talk a little bit about what in lieu of service is, but broadly, before I even start there, this is the idea that there would be a benefit offered in which Medicaid managed care would offer. Each plan has the optional choice to offer a food and nutrition services benefit to certain enrollees who qualify. It's the first time in Michigan, and like Elena said, we were one of the first in the country to put this as an optional benefit for our Medicaid managed care plans inside of their contract. And so, at the time that the Food Bank Council of Michigan joined the Medicaid Food Security Partners Program, we were in the midst in Michigan of the development of that policy provision. And so, I'll talk a little bit about what that policy is, and then we'll get into sort of what happened in that time. So, in lieu of services is one lever that can be pulled of many for Medicaid to participate in the offering of food and nutrition services. But in lieu of services generally means that each Medicaid managed care plan is going to swap out a medical service for this optional benefit that is medically appropriate and cost effective. So they have to prove with a formula that the service that they're going to offer is medically appropriate and cost effective when it's provided as a substitute for other Medicaid covered services. It's important to note that it's fully optional for each Medicaid managed care plan. So they make a business decision of whether to include it or not, but it's not required under the contract to offer to all enrollees. In fact, in our case in Michigan, it can be offered to certain regions of the state and to certain enrollees who qualify. And it's also important to mention that in the state of Michigan, we have 9 different managed care Medicaid plans. And each creates its own plan to offer this optional benefit that has to be approved by the state in order to then enter into contracts with qualified in lieu of service food and nutrition services providers. Our policy in Michigan has 4 different service categories according to the policy, and they align with what Elena was talking about in terms of a food benefit. So medically tailored meals, healthy home delivered meals, healthy food packs, which is a healthy grocery program, and produce prescriptions. Now, in our policy, the actual Medicaid managed care plan is the entity that controls and really is required to conduct all outreach, do the screening, enroll their enrollees, and once they're fully enrolled in the program, they're then referred over to in lieu of service providers who have also applied with the state Medicaid office to be a qualified provider. And a trick of this in implementation has been that once the plan decides to offer it according to our policy, it must be offered to all eligible enrollees in a service category in a chosen region of service. So to those of you who are new to the Medicaid world and the world of this of health-related social needs, it's important to note that this benefit, food insecurity, the social needs screening, is one of 2 components of eligibility for a food benefit in Medicaid. The other is that it has to have a clinical risk factor, and that gets back to this medically appropriate definition that I just talked about, that the service is for food insecure Medicaid enrollees, but they also have to be working on something inside of their health care that is a risk factor that in which food and nutrition services can move the needle on. So next slide. So like I said, it was very serendipitous that we applied to become a partner with the Medicaid Food Security Partners Program at the same time that this policy was being developed, because we were able to work on that policy development and the administrative advocacy, both policy advocacy and administrative advocacy, during the time in which we were a cohort member receiving the technical assistance that Elena just mentioned. So we first worked together on initial responses to the proposed set of nutrition-focused in lieu of services that the state put out for a request for information. So they put out some language and they asked for feedback, and we worked on a lengthy memorandum on behalf of our organization and our members to respond to that. And we did that in early 2024. Then in late 2024, there was a proposed draft of the in lieu of service policy guide that you can now find the finalized draft on our Michigan Department of Health and Human Services website if you're interested. But after that period, they did another open comment period in which we were able to do another round of responses to potentially influence the final version policy. So that happened in late 2024. Then in early 2025, the plans, it then sort of moved into business development mode. So the policy was set, the guide was released, and then it was time to work with the Medicaid plans on their particular implementation plan for this benefit. So we worked on, sort of building our capacity as a statewide network to offer working in the healthy grocery category. That's where our food banks and pantries are working with us as an intermediary that is performing a lot of the administrative function on behalf of our network. And then we began the contracting process with those Medicaid plans. And then on June 1st of 2025, the program went live. So we have about 5 months of experience in implementation now. And so our focus really moved to the implementation of the program. But I think it's important to mention that, one question that may come up is, well, what does, an anti-hunger organization, sort of what can they draw upon to participate in public comment or respond to the policy? We really focused on experiences that our food banks and partner distribution agencies have had with healthcare partnerships and food as medicine programs, and particularly looking at where we have seen success with specific populations for intervention. So who we've worked with, why, what happened, some of the data and evaluation from those food as medicine partnerships over the last decade. We also provided a lot of information about the programmatic components of the interventions that we had offered, mainly through philanthropic food as medicine programs. So intensity, the duration of interventions, and then a lot of information that we had about sort of what infrastructure was going to be needed and the logistics that are needed from the perspective of a food partner that is going to join a Medicaid plan to offer services. We also worked with the technical assistance crew at Health Begins and Medicaid Food Security Network to utilize policy language and lessons learned from other states. So I know Elena's going to talk a little bit about the dashboard that they have, but really drawing upon where there have been successful policy advocacy and development of policy that inures to the benefit of families and children in Medicaid, and also really understanding some of the brass tacks of what it takes to be successful with this work. We know that for food banks, pantries, and other anti-hunger organizations who are new to Medicaid, that they need, for instance, templates for data sharing so that they're not having to reinvent the wheel to figure out how they're going to share data back and forth with Medicaid plans. We also know that negotiating rates as a vendor with Medicaid plans, if you're brand new to that work, that's very hard. So, also utilize state-issued rate schedules from other 1115 demonstrations, which you may have heard of, that large demonstrations in other states within Medicaid to offer food and other social determinants of health. So next slide. So some considerations for community-based organizations. I just started talking about this, but these are definitely some of the tips that we have from 5 months of implementation and in Michigan. And I think that some of the largest have been that normally food banks and pantries and other organizations tend to work very locally or perhaps even regionally, but normally don't move food more than 20 miles. And some do, but it is very different from Medicaid service territories, which can be very vast. And so, for that reason, Medicaid plans really do want to contract with provider or vendor networks. They want to know how they can ensure coverage to all of their enrollees in a service area, regardless of where they live. And so that is a really important consideration in entering the contracting process for a food as medicine benefit or an HRSN benefit, because inevitably that's going to arise that, that you may have a very excellent food as medicine program or capacity in an urban area or in a particular radius, but not outside of that radius. And so how are we going to bridge that? And so in Michigan, we've spent a lot of time working on statewide approaches and this notion of creating a provider network. And that's where my organization, as a statewide organization, has stood up an administrative hub that really can connect all of our food banks and pantries and other agencies that are interested in participating in this program. So, there's also a lot of consideration of what is the benefit itself or the service itself. Like what does the widget that is being offered and contracted for consist of? And that's really difficult because if first you think, oh, the widget is a meal or it's a food box or it's a produce prescription, but inevitably that the work around how you wrap around that Medicaid enrollee to provide support and care coordination and what is the glue across the plan and the enrollee and the food provider creates a lot of questions around case management or care coordination or administrative work that also lends itself to also discussing other wraparound services that your anti-hunger organization may already conduct, like SNAP application assistance or referral or navigation to other charitable food programs. These kinds of things are all sort of like, is that wrapped up in what we're contracting to do? And I think that there's a lot of unsettled territory as we move forward, really thinking about how to structure these agreements so that they are more holistic and less really focused on a fee-for-service payment for a food box or a meal or an individual food item, but thinking in a more value-based way around how we're going to improve the health and wellness of that enrollee together. And that may include lots of things beyond just the food widget, as I sort of say. And that gets me to this next bullet point around a fee-for-service payment, which if you're new to Medicaid means that essentially they've assigned a price tag to that particular box and you're filing a claim to get paid for that food box or that meal, and potentially overhead is wrapped into that, but it's a fee-for-service payment, meaning that that it's a reimbursement for exactly that widget in and out. And I think that the trend that we're seeing is that the goal is really to improve the health and wellness of that enrollee. And so if the plan and the partner that's working on the food program are in alignment on what those goals are for the health and wellness of that enrollee, or if it's, to keep this person out of the emergency room or to lower their cholesterol or whatever it may be, when you align on that, the agreement can be really focused more on the process by which we get to that goal, and we share working on that goal together. So it's a lot of work for the future, I think, but it's definitely the direction that I think the work is trending. Other considerations, I know that a lot of attention has been paid to that when you work with Medicaid versus outside of Medicaid, that obviously compliance with HIPAA and data sharing requirements, data privacy, confidentiality are all very important, and learning how to build that infrastructure to be able to share data securely with Medicaid health plans is a really important component of that. I would also say that that and the invoicing and billing which is the last bullet point here, are both very expensive in terms of labor and just administration of these programs, and often work that community-based organizations haven't had to do in the past. And so often, that is going to take a lot of FTEs to coordinate. And that's another reason, I think, for thinking through a statewide approach and creating some efficiencies in the way that administration is conducted, so that you're not, as an individual organization, really losing your shirt on doing all of that work when you've priced your food widget to really just cover the cost of that food and moving that food around. So those are all considerations in the early days of thinking through participating in a food benefit in Medicaid, at least from the perspective of Michigan. Every state and the way that they're implementing these policies is very different. And so as a result, it's really hard to take directly one-to-one, like what's going on in one state or one case study and apply it. But I do think there are some generalizable principles that do apply every time you start working with Medicaid. And so I tried to focus on those, but there are some really unique aspects to our policy here in Michigan. And I'm happy to answer any questions about that as we move forward in the presentation. So thank you. Back to you, Elena. Oh, I do have another slide. Okay, so I do have a little bit more about implementation, and I think that I can move through these pretty quickly. One question that I get asked a lot about is, we have a pre-existing food as medicine program or partnership at our community-based organization, and we've been working with a provider or a clinic for a really long time, and this is what we offer. And we would really love to see if that could be reimbursable by Medicaid. And unfortunately, one of the things that we've learned in Michigan is that it is very difficult to retrofit a pre-existing food as medicine program into a Medicaid benefit. And one of the reasons is because of all of that regulatory compliance that comes with participation in Medicaid, and also the fact that within lieu of service, particularly, you have to serve the enrollees that the plan identifies. So often what happens is if you're running a produce prescription or a grocery program or a meal program, you may already have a set of participants that are actively working in that program, but you would have to increase your capacity to work with a whole different one in order to receive that reimbursement from Medicaid. So it creates some capacity issues for a lot of small nonprofits, and it's definitely something to consider as you move forward in this work, that it isn't really just laying on a new revenue stream into a pre-existing program. It's really building your capacity to grow, to do more that fits within this Medicaid framework. We're still working out a lot that has to do with cross-sector business arrangements. So can a community-based organization partner with, say, a third-party logistics firm like Amazon to really handle that last-mile logistics, moving their food? And that's happening in a lot of states. And I think there's a lot of really interesting innovation going on. And again, this sort of gets back to thinking through this as a new social enterprise versus a pre-existing food as medicine partnership. And usually the reason that this is so important is that this work does sort of have to scale in order to meet the needs of larger Medicaid contracts. And so it's something that there's a lot of work being done now around sort of like what's the future of that. And also I would be remiss to not talk about the fact that commercial vendors are heavily active in this space. So for nonprofits that are working, anti-hunger organizations, food access organizations, it's part of what you have to kind of decide is what scope and what degree of participation are you trying to have in this space, and how do you enter the market, and how do you succeed in a market that's already sort of flooded with a lot of commercial vendors. So definitely the role of nutrition education and sort of the wraparound coaching supports or motivational piece for particularly chronic disease self-management, or if we're trying to improve diet quality over time. And there is a behavior change component to the intervention. Obviously, there needs to be a role for nutrition education and coaching. And in Michigan, we're also seeking a reimbursement for licensed RDs to receive reimbursement for services and sort of a licensure component to that. That is not yet settled in Michigan. So as a result, getting reimbursement for RD visits has been a tricky component to this. And we're also working through that, sort of what the right level of engagement for that and like how that adds on to several of these service categories. I think I've pretty much mentioned that, that one thing that we're struggling with in Michigan is the difference between addressing a social determinant of health or pure social needs screening and thinking through a health-related social need that also involves a clinical risk factor and sort of what's the difference between the two. I think that there's a lot of misunderstanding that working inside of the Medicaid insurance program can be a purely food access option, and in lieu of service as a lever absolutely cannot be because of all of the requirements for medical appropriateness. This is a medical intervention, and so as a result, there's a lot of documentation around showing why this is a medically appropriate service, and so that does require that you move the needle on a health outcome or that you be working on that. And lastly, I would say, I already talked about care coordination. I would say that sustainability is going to be something that we think about quite a bit in the years ahead. I think that the states that worked in an 1115 demonstration, in which there's funding from the federal government to support that demonstration, potentially made it look as though there's a lot more money in this work than there may actually be. And in lieu of service in Michigan, they did not make a change to the capitation rate or the way that plans get paid to serve enrollees in order to offer this optional benefit. So as a result, it is seen as expensive and difficult. So the notion of like sort of what is the sustainability of this, or what is the true funding, sort of the degree to which you're made whole for doing the work is still very uncertain. And it reminds me of a lot of other federal government funded nutrition programs that our food banks and pantries participate in, like CSFP or CACFP, in terms of the reimbursement model and like the true amount of reimbursement that you're getting for the service. Some of the similar questions are coming up around, is this truly a sustainable option for us to participate in it long term? So now I do really believe I'm done.
No worries. Thanks so much, Dawn. Before we move on to ways that you can continue to stay engaged with Dawn and I or the Medicaid Food Security Network, we wanted to pause for any initial questions. Okay. As you are typing in the chat, we will move on to our next couple of slides, and then we can hang out and chat with you guys. All right, we wanted to share a little bit more about how you can engage with the Medicaid Food Security Network. So this first QR code on the top is a way that you guys can join our network and receive our newsletter. We call this our News Digest. We come out with one quarterly, so you can scan this QR code. And then the bottom is our Medicaid Food Security Network policy dashboard, which is on our website. This dashboard is a list of programs and policy documents from across the U.S., including waivers and Medicaid managed care contracts, to provide examples on how Medicaid is addressing food insecurity among children and families. We update this resource annually. We also welcome any feedback, but hopefully this is a tool that can support you and your organization. And just wanted to say thank you. Thanks for joining us today. We put our contact information here. You're more than welcome to reach out to us with any questions or comments, but otherwise happy to linger on if folks want to chat with us or type anything.
Yeah, it looks like we do have a question from Jennifer. And it is, what is an example of a medical service that would be denied in order to food ILOS?
Sure, I can take that. It's a little bit of more of a creative fiction exercise than this. No one's going to be denied a service. Instead, what the Medicaid health plan has to do is create a document that they submit to the Medicaid office that shows how they believe that offering these food benefits or this food service, in fact, replaces in cost a more expensive clinical service. So, for instance, when they identify a patient, say someone who has uncontrolled A1C, diabetic, and they say, we're going to offer this person healthy groceries, and the cost of this healthy groceries is going to essentially offset the costs that may occur for this uncontrolled diabetic in terms of emergency room services or additional insulin or whatever. I mean, there are a number of arguments that they can make around sort of what clinical services will be not needed because the food is going to stabilize this clinical risk factor. So again, it's more of it's sort of a planning document. It's like, okay, if we offer this thing in lieu of this other thing, we believe that we will spend the same amount of money per enrollee that we are offering Medicaid services to. So what that means is that the service that's offered, the food benefit, really does need to do something that there really is an evidence base to justify that. And I think that's what that's what the plans really have to take a look at with these clinical risk factors, is to say this enrollee has all this stuff going on. We believe that food will be a more cost-effective and medically appropriate service than this other thing that would happen if we did not offer that food service. I hope that explains it a little bit. And again, I don't know exactly which criteria, like I feel like there's a lot of secret sauce in there around how they make those determinations. But that's definitely what the arguments that they have to make to justify offering the food benefit.
And then we also had someone ask about sharing the QR code again. And if you all could share, Alana, the PowerPoints with us, we'll make sure that these are available for you all after the session is over by checking back over here. In this session, it will have a link to documents. So we'll make sure that those are available post-session.
Thank you. Any other questions or comments for Dawn and I?
All right. Well, thank you both so much for your presentation today. Thank you, everyone, for being here. Just a few things to wrap up. Up next, you can choose one of 3 sessions. To join one of these 3 sessions, click on Agenda in your navigation bar to the left of your screen. Be sure to click the right arrow to scroll through all available sessions. And that concludes our time together today. Again, thank you both so much for being here, and I hope everyone has a great rest of your day.